Evaluating the abdominal aorta with point-of-care ultrasound is critical in the acute care setting, especially with a patient who has undifferentiated hypotension or shock, the elderly patient who has abdominal pain and or back pain, but also in the primary care setting because it remains one of the leading causes of death in the United States. But more importantly, a ruptured AAA has a mortality that approaches 90%. And the only way to save most of these patients is to catch these before they rupture. And like many other diagnoses, it is not the exact size that matters as much as the rate of change with the abdominal aorta. If there's a rapidly expanding aneurysm, that is a dangerous situation. And because this is a very time-dependent diagnosis, it's fortunate that point-of-care ultrasound has been proved in numerous studies to be nearly 100% sensitive when used by an emergency physician to rule out AAA. Now notice I said nearly 100% sensitive for ruling out AAA, or abdominal aortic aneurysm, not dissection. Ultrasound is not the test of choice for aortic dissection. For that, you need a CT or a computed tomography. The exam itself consists of 3 cardinal views. You start in the subxiphoid of the patient, which corresponds to the proximal abdominal aorta. In this area, you'll likely see the celiac trunk, which branches into the common hepatic artery and the splenic artery. Just below that, you'll see the superior mesenteric artery. As you descend down to the mid-aorta, you will measure the diameter there as well. And as you move towards the umbilicus of the patient, you should see the bifurcation of the aorta into the common iliac arteries. In all 3 locations, you should try to measure both in the transverse and the longitudinal planes. Because of its appearance on ultrasound, you'll commonly hear the celiac trunk referred to as the seagull sign, with the common hepatic artery as well as the splenic artery as the 2 wings of the seagull, as well as the SMA, or superior mesenteric artery, is referred to as the mantle clock sign because of its appearance as well. Measuring in 2 planes should allow you to accurately measure the diameter of the aorta, as well as categorize what type of aneurysm it is. The vast majority are fusiform, and rarely you'll find a saccular aneurysm. These may have different treatment strategies, therefore categorizing the type of aneurysm can be helpful. Also, it's important to note that the vast majority of abdominal aortic aneurysms are infrarenal, meaning they're below the level of the renal arteries. Therefore, just a proximal view of the aorta would be inadequate. And how we measure the aorta is to freeze the image at our desired location. We will take our calipers and we will measure the outer to outer diameter. That is so we don't miss any aortic aneurysm, because sometimes you can have clot within the aorta, you can have wall that's thickened, and you may underestimate the size if you just measure the internal lumen. So you have to make sure you measure the outer wall, clot, everything, so we get an accurate measurement. The major landmark to identify in your aortic exam is the vertebral shadow. This is because you'll typically see the bright bone of the vertebral body and the nice black shadowing below it, as you see here on this still image. You can typically identify the liver as well in the proximal abdomen, and the aorta typically runs just along the left part of the spine, or on the top of the vertebral bodies. You'll see the inferior vena cava, or the IVC, running along the right side, just adjacent to the aorta. And there are other structures you can identify, as seen in this video. The pancreas will run over the vessels just adjacent to the liver and the proximal portion of the abdomen. But the main focus should be the continued viewing of the vertebral shadow, and then, of course, what we really care about, the diameter of the aorta. Switching the probe 90 degrees with the indicator pointing towards the patient's head, you can now see the vertebral bodies as this bright hyperechoic line beneath the aorta. The aorta is now in a longitudinal plane, and you can see the celiac as well as the SMA trunks in a longitudinal plane as well. You can continue taking measurements of the aorta along the entire long axis. You would do this the same way in the anterior and posterior direction, making sure to include clots and wall thickness. Additionally, applying flow to the aorta can demonstrate false and true lumens, as well as demonstrate flow in the main trunks of the celiac and SMA. Now use this still image to identify all the major structures, including the liver, the celiac artery, the SMA artery, as well as the aorta and the vertebral bodies. In the proximal aorta and the subxiphoid area, the first major branch you'll see is the celiac artery, which will branch into the hepatic artery and the splenic artery. The hepatic artery here is on the right side of the patient or the left side of the screen, whereas the splenic artery is on the left side of the patient or the right side of the screen. Recall this is called the Siegel sign, where the right wing is the hepatic artery, the left wing is the splenic artery, and the body would be the celiac artery. In this still image, try to identify the liver, hepatic artery, splenic artery, celiac artery, as well as the aorta and the vertebral body. Just inferior to the celiac trunk is the superior mesenteric artery. It's typically an anechoic circle just anterior to the aorta and surrounded by hyperechoic fibrous tissue, which makes it look like a mantle clock sitting on the aorta. The splenic vein typically runs just anterior to the SMA, and the left renal vein you'll see in between the aorta and the SMA. And often you'll see the IVC as well, just sitting to the right of the patient or left of the screen of the aorta. Now in the still image, try to identify the anatomy, starting with the aorta and the SMA. Identify the splenic vein, which is usually anterior to the SMA, as well as the left renal vein and the IVC. You can see vertebral shadow, as well as the portal confluence in the liver. As you drop inferior past the SMA, you are in the mid-aorta. Now this is the infrarenal region where most of the aneurysms are found. Take a careful measurement here. Continuing past the mid-aorta to the umbilicus, you will find the bifurcation of the aorta into the iliac arteries. Aneurysms are common here as well as isolated aneurysms to the iliac vessels. Measure the distal aorta, and if you can measure the iliac arteries as well. The iliac artery diameter should be about half the diameter of the distal aorta. Now what is abnormal? Here are the numbers to remember. Greater than 3 centimeters means you have an abdominal aortic aneurysm. Greater than 5 centimeters is typically the number that may require a surgical or endovascular intervention. But remember, it's not just the size that matters, it's also the rate of change. Now let's look at some abnormals so you know what they look like. Here we have a mid-aorta here, and what do you think we see? You guessed it, it's a AAA. It's an abdominal aortic aneurysm that measured more than 4 centimeters. Now this looks particularly scary. This is a large AAA with clot float inside that ruptured into the peritoneum. This is an aortic dissection. Now here's a giant AAA. It's measuring 8.27 centimeters. It has false and true lumens. It has large clots within it and is at high risk for rupture. This AAA is measuring just over 6 centimeters and has this large clot within it that you can see flapping with every beat of his heart. Pieces of this clot can break off and cause problems within the abdomen and the lower extremities. This large AAA demonstrated a possible intimal flap versus clot. And in this setting, you should be concerned for a possible rupture. Last up, we have a pseudoaneurysm of the aorta. This is when, within an aneurysm, the tunica intima and the tunica media are usually violated. However, the tunica adventitia is preserved. These are also at high risk for rupture. Now let's review by looking at a real exam. So you want to choose either a curvilinear or a phased array probe. Those are those low-frequency probes that will help us see deep into the tissue. You're going to set your exam setting either to a fast exam or to a general abdominal exam. You're going to take your probe and point the indicator towards the patient's right. That's going to give you that transverse view that you want to see initially. You will place the probe underneath the xiphoid process, and the patient should lie supine if possible, and you should stand on the patient's right. If bowel gas obscures your view, apply gentle, steady pressure, and that usually resolves it. Right away, I see some celiac artery and hepatic artery. The liver is anterior and the vertebral shadow is posterior. The IVC is very prominent, as well as the portal confluence. The aorta is the pulsating mass on the left side of the patient, right next to the vertebral body. As we go just inferior, we have a great picture of the portal confluence and the splenic vein that sits right on top of the superior mesenteric artery. This is our mantle clock sign. We had a nice view of the hepatic artery and a little bit of the celiac, but it wasn't a great Siegel sign, so we just progressed down to the level of the SMA. Just inferior, we see the IVC with the left renal vein feeding into the IVC. It runs right on top of the aorta. As we progress inferior or towards the patient's feet, we get into the mid-aorta. Notice as we progress in our exam, the aorta becomes more superficial. It's closer to the skin as it becomes lower in the abdomen, closer to the probe. That's because the proximal aorta is retroperitoneal, it's very posterior, but the distal aorta is very superficial. Now we encountered some bowel gas here in our exam, that's why we can't see anything. But as we apply gentle pressure, the aorta becomes very apparent. Now we're going to decrease our depth to get a much better look. And now we're looking for that bifurcation of the aorta, the bifurcation that turns into the two iliac arteries. So we apply a little bit more gel, and now we're going to just fan up and down until we see that bifurcation. And here we are at the bifurcation. We see one vessel at the top, and all of a sudden there's two vessels. One vessel, two vessels, one vessel, two vessels, as we fan up and down on the patient. Now we go in a longitudinal axis. That means the indicator of the transducer is pointing towards the patient's head. And we're going to run up and down on the aorta here. We could measure the anterior posterior diameter just like we would in transverse access. Now we haven't done the measurements in this last demonstration, and that's because it would interrupt the video, and this is better practice in person anyway. So please go to the bedside, practice this in person, make sure that you're doing this correctly, because this exam has just a fantastic sensitivity if you do it right. Please email me any questions. I hope you enjoyed this video. Please scan on, continue to practice, and continue to learn at ucdultrasound.com.